Greetings. My name is Dr. Robert Gish. I am a hepatologist based in San Diego. I spend about half my time working with patients clinically, and about half of that half time is working with patients with fatty liver. Fatty liver, as you know, is an overlap or can be an overlap between metabolic syndrome and alcohol exposure or alcohol use disorder. And of course, every liver patient, we need to take a good alcohol history. And now I'm using not just an alcohol history, alcohol tool such as Audit C. In my written questionnaire, I have a mass test that I use. And importantly, I'm doing blood tests, PETH, phosphatidyl ethanol, in patients at very, very low threshold. But I do tell patients I'm ordering that PEth test to document how little they're drinking. That's a friendly approach. Today, though, we're going to get into another part of the alcohol use disorder world, and that is using motivational interviewing. I've been trained indirectly through different meetings and also directly with some online courses. And motivational interviewing is a key part of my practice for any type of patient with an addictive disorder, whether it's food, alcohol, drugs, smoking, and also just a way to talk to patients in general. It comes back to general healthcare and medical care when you're talking about compliance and adherence. So on those notes, I'm now going to power up my PowerPoint slides and get that organized. It takes just a couple of steps here through share screen and getting to the slide deck and then getting the slide deck to full screen. Okay. Well, motivational interviewing is something I learned about a few years ago when I was taking some courses online through the ASLD in the middle of COVID. And it was a hot topic, but it's very interesting how little is known about motivational interviewing in the hepatology community and even less in GI practices. Although at many meetings over the last, I would say, 18 months, I've brought up motivational interviewing in a very, very large format. So a lot of people have heard about it from me, as well as other providers, maybe in their own institution. Super important tool. I don't have any disclosures relevant to this presentation. I want to thank Peg Dundon, who loaned me these slides. She works at an area or a center for integrated healthcare, and I did update and modify her slides, but these are fantastic and really educated me. So we know that alcohol use disorder is common in liver and GI clinics. Alcohol use disorder is a medical issue in about 15% of the adult patient population. And it's going to be more common in liver clinics, of course, because people are coming in with elevated liver tests or fatty liver or something abnormal on imaging, as well as taking just a good medical history. And AUD treatment, of course, is part of managing all forms of alcohol-associated liver disease, or ALD or AALD. Provider attitudes towards treating alcohol use disorder on this slide. On the left side is people don't prescribe. People are referring to psychiatry. They're concerned about drug costs, side effects. A number of issues come into play when providers don't get involved or why they don't get involved with treating AUD. And they're less familiar with the medications. You can see here that most providers don't prescribe anything for alcohol use disorder. On here is my favorite, baclofen. Disulfiram, I don't think ever should be used. Acamprosate's coming into more utilization these days, but it's a large pill burden. I really like gabapentin and naltrexone. I think those are quite good. Topiramate's another option, but the utilization of this is low, as demonstrated here. Little bit more about provider attitudes. Lack of training is one of the biggest issues. And I would say training and motivational interviewing in my community is probably around 1%. First line interventions, of course, a referral or partnership to an AUD or SUD type clinic, substance use disorder treatment. And I have that available in my different clinic locations at different levels. And some places it's formal, some places less formal, but really the message to patients and providers is to be a multidisciplinary team and utilize pharmacotherapy. To change, people are generally better persuaded by themselves to themselves, reflexive, than having another come in and try to do an active, directive intervention. Motivational interviewing is a person-centered, goal-oriented approach for facilitating change through exploring and resolving ambivalence. Ambivalence is about their psychiatric issues, psychological issues, abuse issues, food eating disorder, alcohol use disorder, drug use disorder, and this ambivalence can hopefully be corrected, redirected for a positive change. The goal of motivational interviewing is to facilitate information, thinking about liver health, body health, moving this to a positive life extension, improving quality of how people can feel better. So these are all positive choices that I use in my practice. If you engage in a direct dialogue and partnership, it's key. You're seeing eye to eye. It's not directive. It's not condescending. It's not pedantic. It's not a lecture format. It's really about a partnership. It's really about a dialogue, and then bridging gaps and helping to not necessarily resolve mixed feelings, but to improve or decrease those mixed feelings, those ambivalence that people can see. Autonomy, more important than authority. Collaboration, you exchange for confrontation. Evocation versus education, so you actually have the client become your teacher. Communication is a dance, not a tug of war. Directed therapy, motivational interviewing is about that dance metaphor. There is a brief motivational interview. This is very important. I was just giving a very similar talk in Vietnam 2 days before I'm recording this. Just so everybody's aware, this recording is on Monday, August 12th for your upcoming meeting. But I learned a lot culturally. And in Vietnam, my colleagues taught me that there's different ways you could use motivational interviewing depending on the education level, social and financial level of your patient. Because they may have food insecurity, or maybe they can't read, or they have not heard of psychological intervention. In Vietnam, alcohol is part of socialization. And if you remove alcohol, in some clients, some patients are decreasing their ability to remain socially integrated. Motivational interviewing needs to be culturally sensitive. I choose motivational interviewing in my practice because I really believe this is an effective, positive dialogue you can have with patients. And I've seen, and I'm really motivated because I've seen so much positive behavior change. I have now confidence in this tool, and we build confidence in our patients and our clients through our self-confidence on how this tool may work. Now, the client-centered approach does need to be organized and in a sequential fashion. And that does come back to personalized care, because it really has to be customized on how the conversation starts. What's the patient's body language? I just took another course in body language, both for assessing and seeing how people respond. This is client focused, and the person needs to become personally aware of the importance of change and how that change can improve their life. And at the same time, you're asking questions about barriers. You're asking questions about history. You may take a history on PTSD or some type of physical or sexual abuse, or ongoing depression, or bipolar, or a personality disorder, or a borderline personality. These things can actually take place pretty quickly. And of course, time compression is important. Primary care providers are seeing up to 40 patients a day. Specialists typically around 20 patients a day. So you don't have time to do a 30 or 60 minutes classic motivational interviewing. You're going to need to use the tools I'm talking about today and come up with a compressed version that's patient directed. Of course, the advantages have to do with listening and reflecting. This allows that trust to build and openness to become more developed. Yes, you can do a quick assessment once you're fully trained and you learn how to customize this to individual patients. There's this pre-contemplation, contemplation, preparation, and then action that would then go into a maintenance mode and hopefully bring that relapse frequency number and event rate to a minimum. Termination, I really don't like that because I really think this is an ongoing cycle indefinitely for the provider, patient, client relationship. Predictors of behavior change really have to do with that commitment language, commitment body language, voice, tone, responsivity, to see about desire, ability, reasons, and need. These are different ways of language positivity. Have the individual say less beverages, less alcohol, elimination eventually, not drinking for part of the day, having alcohol-free meals, alcohol-free days, then alcohol-free weeks. These are all positive messaging. So open questions, reflective listening with that bounce back, that dialogue, and then use your language, your tone, your words to help build that motivation. And we'll come back to summarizing at the end of this lecture, which I'll have a summary, but it's also a signal to summarize what did that person communicate during the dialogue. The patient can do a summary, or you can have the provider do the summary, or both. So eliciting change, you need to have these skills, the ability to elaborate, firm messaging, back to reflection, taking what the client said, putting it in slightly different words, in a partnership manage, then of course, summarizing at the end. Keep it simple, 3 thoughts, for example. Open questions are very, very useful. Open questions can promote change through problem recognition, expression of concern. That could be provider concern or patient or family concern. Is there an intention to change? And then asking about what are the tools to fulfill that intention, keeping things optimistic. In that reflective listening, you're going to be hearing, you're going to say what you hear, what you think you hear, reflect back to the client. You can make a guess, but you're not really using the word guess here. You're making a word such as estimation or possibilities, or this is what I've heard. And then that allows the client, the patient, to come back and even modify what they think that they're saying. More and more here on forming reflections. Sometimes you can shorten that, saying it appears you're ready or not ready. I hear you're having a problem. I hear you have a solution. I understand your feeling. Here where I hear for your troubles. And then coming back to values, importance, and confidence in that individual to build motivation. Values need to be brought into this. How I use the family and health issues is how do you want to feel in 5 and 10 years? How would you like your sleep habits? Would you like to feel less depressed or less anxious? Do you wish to see your children, your grandchildren grow up and be part of their life, in a healthy way so you can participate and decrease issues and complications of alcohol use disorder? We often see injuries, trauma. People are often separated from family members because of challenges, and how to bring that back together, how to bring the family back together. So importance and confidence. Importance, of course, lets you know that you may motivate a person for behavioral change while bringing down barriers, while building confidence that that person can carry that change outside the office and outside the counseling session. Now, you can have scoring systems from 0 to 10 in these slides, which I'll share with your team. There's some interesting scoring systems in hidden slides. So summarizing this event, this presentation also allows you to think about summarizing your interaction with your colleague, your patient, your client that you're working with. And this helps you as a provider understand what happened during that session. But more importantly, it helps the patient reflect and understand what they heard. And each time you have a session with them, you can build this reflection, build this conversation, but ask your patient, ask your client to be doing this at home daily and say, what did you hear yesterday? What did you hear a week ago? And the provider visit, and have them repeat that back to themselves or family members or partners or significant others. Wrapping things up on the way out to the clinic, on the way out the door, you're summarizing before you depart the room about a partnership, building understanding, decreasing ambivalence, clarifying messaging, clarifying directions, and really back to building motivation. I often describe to my patients that when you are born, you're given 100 years. You take care of your health, your life, through these different positive health behaviors. You can make it to 100 years, but how to make it there? You need to, of course, you stop alcohol intake, you have improved general health, you decrease cancer risk, you improve liver health, you decrease issues such as violence, car accidents. There's other things that happen in that alcohol environment. And you can rebuild relationships, heal relationships, bring family back together, because family support, I think, is super important. So listen well, spend more time listening than speaking. Elicit answers through directed questions, reflection, then back to summarizing and bringing that relationship between the provider and their client back to this metaphor of being in a dance. There are many resources, but this motivationalinterview.org, I think, is a fantastic resource. I'd like to thank you for having me here today. Any feedback on this presentation, I would much appreciate, and I look forward to being part of your presentations in the future. Thank you so much. This is Dr. Robert Gish, hepatologist, San Diego.